In the name of Allah, the entirely merciful, the especially merciful. Let's break down the molecular blueprint of albumin that makes it so effective. It's a globular, water-soluble protein, shaped for easy travel in the bloodstream. This single polypeptide chain is remarkably stabilized by 17 disulfide bonds, acting like crossbraces that give it a durable, robust structure. A key feature is that it's unglycosylated. However, over time, it can undergo a slow, non-enzymatic process called glycation, which is inhibited by antioxidants. This glycation can lead to the formation of advanced glycation end products, AGEs, which are associated with long-term diabetic complications and inflammation. With a molecular weight of 65,000 daltons, it's just large enough to be retained by the kidneys. But the real renal protection comes from its negative charge. Since the glomerular basement membrane is also negatively charged, they electrically repel each other. This charge barrier is a primary defect, preventing albumin from being filtered into the urine. A defect in this charge is a classic cause of pathological albuminuria. This slide truly showcases albumin's role as the bloodstream's most versatile cargo ship. Its binding capacity is vast and critical for the function of numerous systems. It carries essential hormones, including thyroid hormones and other fat-soluble hormones, ensuring their delivery to target tissues. It binds and transports other proteins and vitamins, like alpha-fetoprotein and the crucial vitamin D binding protein, which is essential for calcium metabolism. A key distinction is its role with electrolytes. It transports divalent cations, like calcium and zinc, but not monovalent cations like sodium and potassium. Or, it is a primary carrier for fatty acids, making it fundamental to energy metabolism. And as we mentioned earlier, it acts as a scavenger, binding free radical species to mitigate oxidative damage, and transporting fat-soluble vitamins. In summary, without albumin, the distribution and availability of critical molecules would be severely compromised. We must add one of the most critical and well-known transport functions to this list, the carriage of bilirubin. In healthy patients, albumin is the primary and essential transporter for unconjugated bilirubin. In fact, almost 100% of bilirubin is tightly bound to albumin and carried safely through the bloodstream to the liver. This binding is vital for two key reasons. First, it renders the bilirubin non-toxic, preventing it from crossing the blood-brain barrier and causing kernicterus in newborns. Second, it efficiently delivers the bilirubin to the liver for the essential steps of conjugation and eventual excretion in the bile. This underscores a key point: in states of hypoalbuminemia, the blood's capacity to safely transport bilirubin is compromised, which can have serious consequences. This relationship between albumin and bilirubin is not just physiological, it's a critical clinical safety issue. The core principle is this: as long as bilirubin is bound to albumin, it is not toxic. It is safely sequestered. However, in states of hypoalbuminemia, there are fewer bindings available. This means more bilirubin is free, or unbound, which dramatically increases the risk of bilirubin toxicity, most dangerously kernicterus in newborns. The problem is compounded by certain drugs. In a patient with hyperbilirubinemia, you now have the additional threat of toxicities from other excess unbound circulating in the body. Key drugs that are known to compete with bilirubin for albumin binding sites include NSAIDs like aspirin and phenylbutazone, and warfarin. It's important to know that NSAIDs themselves are typically over 90% protein-bound, so they are highly likely to displace other substances. This competition pushes both bilirubin and the drug into the unbound, active, and toxic state. This slide provides a comprehensive list of albumin's passengers, but more importantly, it reveals its higher role as a master regulator and protector. We see the usual suspects: fatty acids, bilirubin, and bile acids. We see essential minerals like calcium, iron, copper, and zinc. We see drugs and amino acids like tryptophan. But the critical point is in the conclusion: by binding these substances, albumin actively regulates their availability. It acts as a buffer, controlling the free, active concentration of hormones, metals, and drugs in the bloodstream. Furthermore, this binding has a direct protective function. By chelating metals like copper and iron, it inhibits their pro-oxidative effects, preventing them from catalyzing the production of damaging free radicals. It similarly stabilizes fatty acids. So, albumin is not a passive cargo ship, it is a dynamic, active manoplasma environment, crucial for both delivery and defense. This slide delivers one of the most important corrective messages in clinical medicine regarding albumin. Serum albumin is classified as a negative acute phase protein. This means that during systemic inflammation, the liver actively downregulates its production to prioritize the manufacture of positive acute phase proteins like CRP. Therefore, a low serum albumin level in a hospitalized or critically ill patient is not a valid marker of nutritional status. Rather, it is primarily a marker of the severity of the inflammatory state. Using it to assess nutrition can be dangerously misleading, as it may not reflect true protein energy stores. And as a final, specific example of its protective role, albumin prevents the photodegradation of folic acid, showcasing yet another way it preserves vital molecules in the body. Thank you.